Hello, my name is Peter Riedell from the University of Chicago, and today I'm joined by Dr. Nilanjan Ghosh of Atrium Health Levine Cancer Institute in Charlotte, North Carolina. And today we'll be discussing relapsed and refractory follicular lymphoma, and particularly focusing on risk stratification and some practicalities of managing CAR T-cell therapy in this population. So in terms of agenda items, today we'll be focusing on three main things. First, utilizing prognostic factors in follicular lymphoma to identify high-risk patients and guide treatment decisions. Then we'll circle to looking at latest evidence for CAR T-cell therapy in relapsed refractory follicular lymphoma, and particularly focusing on their place in the treatment sequence and considerations in relation to patient selection. And lastly, we'll be focusing on managing the practicalities of CAR T-cell therapy in the clinic with a specific focus on the safety and the multidisciplinary team approach. So for our first session, we'll focus on utilizing prognostic factors in follicular lymphoma to identify high-risk patients and guide treatment decisions. So in follicular lymphoma, there's certainly some challenges that this disease presents. And often the key considerations when we're managing patients with follicular lymphoma include those in relation to timing of initiation of treatment. Also, of course, there's the conversation about what are the optimum frontline treatment approaches, and also those approaches in second and later lines of therapy. When managing patients with follicular lymphoma, especially in the relapsed or refractory setting, it's often necessary for us to do imaging evaluations to particularly focus on evaluating for transformation, and in the context of things like an elevated LDH or really a significant constitutional symptom, certainly considering a biopsy would be necessary in those patients. The other key prognostic factor that we think of in follicular lymphoma includes those patients that have progression of their disease within 24 months of initial therapy. That's seen in approximately 20% of patients, and we know that those patients unfortunately have a poor outcome overall. When we consider therapy, there's some particular considerations in terms of balancing things like meaningful remissions, palliating patients' symptoms, and of course prolonging their life, but at the same time balancing that among the cumulative toxicities of therapy and the potential impact of those toxicities on mortality and morbidity. In follicular lymphoma, there's a lot of heterogeneity, and based on this clinical heterogeneity, really the decision of when to treat is as important as the decision on how to treat the patient. And cumulatively, we need to really use these different prognostic indices that we'll get into to potentially guide that. But ultimately, the decision is really individualized in these contexts. And so focusing a little bit on prognostic markers, there's been now a number of models that have been utilized in the clinical setting to prognosticate outcomes in patients with follicular lymphoma. When we look at on the left of the slide here, it focuses on the risk factors, and particularly if we look at things like advanced age, advanced stage disease, and other things like elevated LDH, bone marrow involvement, and impaired performance status, those all have been sort of markers that, despite the different risk stratification systems, have borne out as important factors that do impact patients' survival with follicular lymphoma. And in the clinical setting, as you can see on the right, we use a number of these indices. One of the ones that I would also focus your attention on is the POD24. And as I mentioned, this is seen in approximately 20% of patients and is associated with poor survival in those that have progression of disease within the first 24 months after initial therapy. So now we have some audience questions, and I'll be posing these to you, Dr. Ghosh, in relation to risk stratification and prognosis in follicular lymphoma. So first question relates to the NCCN guidelines, and we're all familiar with these, and they provide some parameters in relation to both the Guelph criteria and the FLIPI score in terms of prognostic models that may help guide decisions when making treatment decisions, for patients with newly diagnosed follicular lymphoma. In your practice, is there one that you particularly use when determining when to start treatment in a patient with follicular lymphoma?
It's a great question, and it can be confusing. But let me clarify. So Guelph is a set of criteria which helps us in deciding if a patient who is diagnosed with follicular lymphoma needs treatment more immediately. And FLIPI is a prognostic tool. Guelph criteria looks at things like, tumor bulk. Is there a tumor size greater than 7 centimeters? Are there multiple tumor sites which are more than 3 centimeters? Is the LDH elevated? Is the beta-2 microglobulin elevated? Is there organ dysfunction and so forth, or B symptoms? So it kind of tells you that, yes, if people have these criteria, either the clinical criteria or lab criteria, or even cytopenias, then they should be treated sooner than later for follicular lymphoma. FLIPI has a different purpose. The name FLIPI stands for Follicular Lymphoma International Prognostic Index. So what it does is it categorizes patients with follicular lymphoma into 3 categories, and they include low risk, intermediate risk, and high risk. And the interesting thing is there are some criteria on the FLIPI which are also on the Guelph.
Right.
So, that's where it can get a little confusing. One example would be a low hemoglobin or an elevated LDH. So basically there is some overlap, but the intent for those two are different. One is a prognostic tool, the other one tells you that you need to treat now.
And the second question for you is related to, are there specific prognostic models that can help identify patients who are likely to have early relapse following frontline therapy?
Yeah, that's a great question. So in terms of prognostic models, what we do know is for patients who are treated with chemoimmunotherapy in the frontline setting, if they are a male, if they have a high-risk FLIPI score, if they have elevated beta-2 microglobulin or a poor performance status, then they may have a higher risk of being in the POD24 group. But it's not an absolute.
Mm-hmm.
There are lots of different prognostic tools which are being developed to help identify the people who are going to relapse early, okay? But there is no absolute thing that, if you fall into one category, then it's a guaranteed that they'll be in the high-risk group or not in that group. So, you showed some in your in the slide earlier, which was the PRIMA PI. There is FLIPI-2, both incorporate bone marrow involvement. Then the M7 FLIPI, which is a 7-gene signature, which is incorporated, again, to try to enrich both ways. One, if you can identify people who are going to do really well, and then identify also the group which is high risk, and hopefully intervene in a way that it can overcome the disease biology. I think the field is moving in that direction. We are not there yet, but it's well recognized that POD24 is a high-risk population. And in terms of the survival outcomes, we do know that patients who are in POD24, their 5-year survival is really not as good as patients who are not in that group, about 50%. So compared to much better, like closer to 90% in those who are not in POD24.
Thank you. So Dr. Ghosh, I have a male patient aged 61 years of age with a preserved performance status of 1. They were first diagnosed with stage 3A follicular lymphoma. I previously treated this gentleman with R-CHOP 18 months ago, and unfortunately he's now relapsed on maintenance rituximab therapy. Are there any measures or other metrics that you would use to help guide second-line treatment decisions in your practice?
Yeah, unfortunately, there aren't any specific measures or tools which help us guide second-line treatment or prognosis or risk stratification in this setting. However, having said that, the fact that your patient relapsed within 18 months of frontline chemoimmunotherapy, that itself puts this person at POD24. And so because of that, what I would do is first I would rule out transformation to aggressive B-cell lymphoma. And if you have not had a PET scan done or a biopsy, if there is a very high avidity PET lesion, that's what I would do. If your patient has had low-grade follicular lymphoma relapse, then one thing I might consider is a lenalidomide-based treatment with a CD20 antibody because you treated the patient initially with chemotherapy. So trying to do something different. There are other options. You can do chemoimmunotherapy again, like bendamustine plus a CD20 antibody. And then I think I would consider this patient for an autologous transplant. There have been some reports of autologous transplant having benefit in this group of patients who belong to POD24. And I wish we had tools to figure out what to do. There are some clinical trials ongoing which may help tell us whether one treatment is better than the other, or may perhaps risk stratify even better, but we just don't have those as of today.
Mm-hmm. I agree. It can be often a frustrating clinical situation when there's not really anything that we have to guide our treatment decision-making in this context. And so my next question relates to my patients who have already relapsed on 2 or 3 therapies. Is there a prognostic model that I could use to potentially predict response to next-line treatment?
So far, the prognostic models we have in follicular lymphoma take baseline characteristics prior to treatment, initial treatment, and help prognosticate how patients are going to do in the long run. If a patient has relapsed multiple times, and especially if the durations of remission are going down, I think that by itself inherently is telling us that this is bad disease biology. And in some ways, we may not even need a prognostic model to tell us that this person needs some novel treatment or something else to try to overcome that bad disease biology. So, the clinical nature of the relapse is often dictating how things are going here. And I'm not aware that any specific prognostic models at that time of second, third, fourth relapse will help us predict how they're doing, other than the clinical behavior of the disease.
Mm-hmm. So more so that the predictive models that we reviewed are more relevant in the frontline setting and not as much in the relapse or refractory setting.
Correct.
So in this session, we'll discuss the latest evidence for CAR T-cell therapy for relapse refractory follicular lymphoma, particularly focusing on their place in the treatment sequence and considerations for patient selection. So when we look at the NCCN guidelines, it does provide some highlights in terms of how to manage patients with relapse refractory follicular lymphoma. And there are certainly preferred regimens for patients that are fit and otherwise healthy. And in the second line setting, things to consider would be bendamustine in combination with an anti-CD20 monoclonal antibody, such as rituximab or obinutuzumab. Additionally, we utilize agents like CHOP in combination with an anti-CD20, or also considering even dropping the anthracycline and using CVP in a similar manner. One of the more preferred regimens in the second line setting may also be lenalidomide and rituximab therapy, as this is generally well tolerated. In the otherwise in the follicular lymphoma setting, we also have small molecule inhibitors, including the PI3 kinase inhibitor copanlisib. We have the EZH2 inhibitor tazemetostat. And now we have 3 agents that are all sort of T-cell mediated therapies in the relapsed refractory follicular setting. We have 2 CAR T-cell therapies, including axicabtagene ciloleucel, along with tisagenlecleucel. And then more recently, we had the FDA approval of mosunetuzumab, which is a bispecific antibody. So when we particularly focus on the use of CAR T-cell therapy in relapsed refractory follicular, I think it's important for us to highlight the efficacy. And so the first product that was FDA approved in follicular lymphoma was axicabtagene ciloleucel, or Axi-cel. It was approved back in 2021 in the third line setting in follicular lymphoma. And that was based on data from the ZUMA-5 trial that enrolled 124 patients. This was a heavily pretreated patient population. With this agent, Axi-cel, we saw an overall response rate of 94% and a complete response rate of 79%. And with the 3-year follow-up, we have a median duration of response of close to 40 months. Tisagenlecleucel, or Tisa-cel, was a second FDA-approved CAR T-cell therapy for follicular lymphoma. It was approved in 2022, also in the third-line setting, and that was based on data from the ALARA trial. That enrolled around 100 patients, and additionally and similarly had a high-risk patient population. Tisagenlecleucel in this context produced an overall response rate of 86%, with a complete response rate of 69%. We also have another agent that's in late-stage clinical development in the relapsed refractory follicular setting, and that's lysocatagene maraleucel, or liso-cel. And it was evaluated in the TRANSCEND study. This similarly enrolled a patient population that was heavily pretreated and high risk. And in this setting, we saw an overall response rate of 97% and a complete response rate of 94%. Of course, all of these agents do appear relatively active in this disease context, although it would certainly be helpful for us to have more mature follow-up to understand how to best sequence and utilize these agents in this disease. And so, Dr. Ghosh, now let's consider some questions from the audience on the latest evidence for CAR T-cell therapy in treating patients with relapsed refractory follicular lymphoma. And Dr. Ghosh, what do the guidelines say about CAR T-cell therapy use in patients with relapsed refractory follicular lymphoma? If you're able to elaborate on any real-world evidence to support those guidelines.
Yeah, that's a great question. So the guidelines say that for patients who have had 2 prior lines of therapy, there are currently 2 CAR T-cell products which are available to use commercially. They include axi-cel and tisa-cel. The guidelines don't help us choose between the 2 because there is no randomized trial which has compared these 2 agents head to head. So that's an individual discussion, but both have been shown to be very effective in follicular lymphoma. So excellent options. In fact, we do have some real-world evidence to support the guidelines. And that was recently presented at the summer meetings at both ASCO and EHA, showing that patients who received axi-cel in the real world had very good efficacy, similar to what was seen on the clinical trial. And even though many of those patients would have not been eligible for the clinical trial because of comorbidities or so forth. But really, again, supporting the guideline with real-world evidence from the CIBMTR showing fantastic efficacy with CAR T-cell therapy in follicular lymphoma relapse setting.
Thank you. And I was curious if you might be able to explain the best approach for sequencing CAR T-cell therapies relative to other treatments that we have at our disposal, things like chemotherapy, immunotherapy, and even other novel agents like I discussed, tazemetostat and copanlisib.
So this is really the million-dollar question, right? Because clinical trials are always looking at, one individual treatment, but not many clinical trials address sequencing of therapies. And that is difficult to do. So I think we'll need some real-world evidence in that. But, it is very promising that bispecific antibodies and CAR T-cell therapies have come in the space. And, there is a little bit of difference between the 2 in terms of access, right? Bispecific antibodies are off the shelf, and mosunetuzumab can be given all outpatient. CAR T-cell therapy takes time to manufacture. It would need places which are CAR T centers. If you take access out, then it really becomes a choice and a discussion between the treating physician and the patient as to which way to go. But because bispecifics are much more readily available and easier to do, and not only that, it is also mosunetuzumab is also not indefinite therapy. It's a defined time period of treatment. So I think that makes it also lucrative because patients don't want to stay on treatment forever. So I think it's really a discussion of pros and cons of what to do with your patient. But it's great that both are available. And beyond this, of course, we have targeted, small molecule inhibitors. Tazemetostat is approved, and copanlisib, which is a PI3 kinase inhibitor, is also available. So lots of different treatments available for patients. How to sequence them? I don't think we have the perfect answer as of today, but more to come.
So now we'll look at. I wanted to see if, Dr. Ghosh, if you were able to identify which of my patients with relapsed refractory follicular lymphoma are eligible for CAR T-cell therapy, and who is really the most likely to benefit from that treatment? And is there a patient that I should refer to a specialist center for evaluation? How does that come into the conversation, and how do you approach that?
Yeah, that's a great question. So patients have to fail 2 prior lines of therapy. That's on the label. And beyond that, I think on the clinical trials, really high-risk patients who otherwise we would have thought would not have benefited from other treatments. Patients with POD24, patients with high-risk FLIPI, failed multiple lines of therapy. I think if your patient is failing multiple lines of therapy and the duration of response with each treatment is going down, then you know that this patient has a bad disease biology. And perhaps CAR T-cell therapy might be able to overcome that. And that's what, when you look at the results and see the PFS results or the CR, a complete response rate, you really, it's striking that this very high-risk group of patients were able to get such a high response rate and high, really good progression-free survival data. So beyond the disease part, patients in general would be able to get CAR T-cell therapy if they have a relatively good performance status. Age is not really a barrier. They have to be committed to a intense treatment, but a one-time treatment. There is a time period where they may have side effects, so they may have to be intensely monitored. They would need some caregiver support. So there are some social factors as well, which may drive, if your patient is going to be eligible for, or if it's feasible. But, in general, the important message is if a patient is not really a transplant candidate, they can still be a CAR T-cell therapy candidate. And age really is not that much of a barrier here.
Yeah, I think those are some very important points. And the other thing I would also maybe highlight is, I think the other thing to emphasize is referring patients early for CAR T-cell therapy. Often we see where sometimes the disease can progress during that time and be a little bit harder to treat if the referral is not made early, and potentially compromises patients' chances of responding.
Very much so, yeah.
So my next question for you, Dr. Ghosh, is it mandatory to incorporate bridging therapy prior to starting CAR T-cell treatments? And is this something that you typically do, or how do you approach the use of bridging therapy in CAR T treatment?
So first of all, it's not mandatory that you have to use bridging therapy. The decision to do bridging therapy is something which you make a decision based on looking at the disease, pace of the disease. So if someone's follicular lymphoma is progressing fast, and you know it's going to be at least a month and a half before you can actually get them to the CAR T-cell therapy because of manufacturing time or insurance clearance or other barriers, then you would want to use bridging therapy to keep the patient's disease controlled so that they are able to get the definitive treatment down the road. On the other hand, if the disease biology is such that it's behaving relatively well controlled with whatever treatment you've had so far, then you may not have to use bridging therapy. But the important thing over here is to identify which bridging therapy you want to use. So, remember, with bridging, all you're doing is trying to buy time and control the disease a little bit. So if there is, you need local control, radiation is a good one, right? You can also use steroids. There are other agents which can be used, like monoclonal antibodies, rituximab or brentuximab, small molecule inhibitors. But there is one agent you'd like to avoid, especially before collecting the T cells, and that is bendamustine. Because bendamustine can kill T cells, and you don't want to kill the T cells before collecting them. So, in fact, there was a very recent article which was just published in the JCO, not in follicular lymphoma, but in DLBCL, showing the bad outcomes or worse outcomes if patients had received bendamustine prior to collection of T cells. So, in CAR T cell therapy.
Thank you. What hope is there, Dr. Ghosh, for my patient with relapsed refractory follicular lymphoma that's more heavily pretreated and may not be eligible for CAR T-cell therapies, whether that's based on disease or whether that's based on other logistics? Are there other novel therapies currently in development for patients like that?
Yes, for sure. Lots of novel therapies are in development. Bispecific antibodies, one has already been approved, mosunetuzumab. There are others which are in development. So that's another that harnesses the T cells of the patient to help fight the lymphoma while binding to CD20 or other novel antigens. Then you have tazemetostat, which is already approved for follicular lymphoma. PI3 kinase inhibitors like copanlisib are already approved. And then others which are not yet approved but promising. For example, zanubrutinib, which is a BTK inhibitor, has shown really good activity in combination with rituximab in this disease. And there are antibody drug conjugates. One comes to mind, loncastuximab, tesirine. Even though not approved for follicular lymphoma, the early phase studies showed really good activity in follicular lymphoma. So it's been remarkable progress for treatment of relapsed refractory follicular lymphoma so far.
And in this section, we'll focus on managing the practicalities of CAR T-cell therapy in the clinic, and really doing a specific focus on safety and the multidisciplinary team approach. So when we think about CAR T-cell therapy in the relapsed refractory setting, we have now 2 FDA-approved agents and 1 agent, lisocabtagene maraleucel, or liso-cel, which is in late-stage clinical development. Particularly focusing on the safety profile of axi-cel, we can see here on the left that this was evaluated in the ZUMA-5 trial. And cytokine release syndrome was one of the most common side effects that we noted in this trial, seen in about 78% of patients. But we can see that largely this was lower grade in terms of its manifestations. We also saw neurologic toxicity as one of the more common toxicities that we see with CAR T-cell therapy, and it was seen in 56% of patients in the ZUMA-5 trial. Other common toxicities would include blood count abnormalities or hematologic toxicities, along with infectious complications, which were seen in 18% of patients. The ALARA trial evaluated TCGen like lysocabtagene, and in terms of potential side effect profile, we saw cytokine release syndrome in approximately 50% of patients, and neurologic toxicity in around a third. Again, hematologic toxicity and infectious complications were common in patients undergoing this treatment, seen in 69% and 5% patients respectively. The TRANSCEND follicular lymphoma trial evaluating liso-cel in the relapsed refractory FL setting, and also we can see here it's associated with common side effects including CRS, neurologic toxicity, along with infectious complications. So when we look at utilizing CAR T-cell therapy, it's important to use a multidisciplinary team when really operationalizing this treatment and specifically managing patients safely. And this really is a collaboration between the authorized treatment center and community oncology centers. So when we look at the left here, authorized treatment centers really have a network of providers that help to navigate this treatment process for patients. That starts with the treating oncologist, of course. We also have the nursing staff, the pharmacists. We often collaborate with our specialty colleagues, including cardiologists and neurologists, when managing potential side effects and complications from CAR T-cell therapy. And ultimately, this team is going to be utilized to really safely manage these specific complications and side effects. And that's also done in concert with patients' caregivers, which really play an active role in monitoring and assisting with this treatment process. It's important to emphasize that this is really a collaboration between an authorized treatment center and a community practice setting. In terms of things in the community setting that are more relevant would be things like potential late emerging side effects like infections, prolonged cytopenias, and also there is a risk of secondary malignancies with these types of treatment. And so Dr. Ghosh, we have some audience questions that I'd like to pose to you and really discuss and drill down on the practicalities of CAR T-cell therapy in relapsed refractory follicular lymphoma. And so my first question, I was curious if there are specific risk factors for the development of CRS or ICANS or neurologic toxicity and other side effects of CAR T-cell therapy. Is there anything that we have that would be predictive? And in your clinical setting, how do you specifically manage these?
Yeah, very important question. In terms of risk factors, one comes to mind is high disease burden.
Yeah.
So if there's a patient with a high disease burden, then the risk of developing side effects like CRS or ICANS is higher. There are other serious side effects as well. Like there is a syndrome called HLH, which can sometimes happen, after CAR T cell therapy. So these are things which are monitored very carefully at the treatment centers by a team which has the expertise to manage this. The treatments, there is grading for each of these. For example, CRS can be graded as grade 1, 2, 3, 4, same for ICANS. And then in general, they're managed depending on how intense the grading is. So for low grade, often antipyretics, and then drugs like and as the intensity gets worse in CRS, the use of a drug called tocilizumab has been very effective in combination with steroids sometimes. In terms of ICANS, steroids are sort of the cornerstone for the treatment of ICANS. There is also investigation such as, sometimes we often do a MRI of the brain. We also like to prevent seizures, but seizures can happen as a part of the neurologic toxicity. So we give seizure prophylaxis, but some patients may need some EEG monitoring. So, and if CRS or ICANS are become more intense, then a higher level of care and involving some of the specialists you talked about, like neurologists or pulmonary critical care doctors are important. So the treatment is usually, handled by specialists who really know how to manage this a lot. And the important message, though, is for the most part, these side effects are reversible. Yeah. Right? So, even though the incidence, and you showed it really nicely in the slide, is high, the mortality related to these side effects is low.
Thank you. So as a community oncologist, what sorts of complications should I be aware of when patients return to my care following CAR T cell therapy? And are there any recommendations that you may have for managing and handling those?
Yeah, so this is a very good question. So CAR T toxicities can be, both, the acute toxicity, which is managed in the CAR T center, and when the patient is going back to the community, there can be, other things like cytopenias. So common one is neutropenia, and neutropenia can be managed by giving growth factors, and then there is also lymphopenia, which can be also associated with low immunoglobulin levels, and that can put both these can put people on at risk of infections. So what I would suggest is a very good academic community partnership, and really help our patients get back to the community, get back to their treating physicians, but help manage these. For low immunoglobulin, sometimes we give IVIG. There can be preventive antibiotics which can be used. For example, patients who go through lymphodepleting chemotherapy often have low lymphocyte counts for a while, which may put them at risk of things like PJP or zoster, and we use antibiotics and antivirals to sort of prevent these from happening. So that the other thing which I wanted to bring up, since you asked, is that fatigue. With CAR T cell therapy, sometimes there's the inflammation, and it causes a lot of fatigue, and it can take some time for patients to get back to where they were before. So sometimes it's just supporting them through this, and while they have had this one-time treatment, there can be some lingering effects which can be there, and just providing that support and reassurance to help them get back to their baseline is really needed. So I think the psychological component of that is also very important.
Thank you. And so next question I have for you, Dr. Ghosh, is how do I monitor for potential infections following CAR T-cell therapy? Are there any specific monitoring requirements that I need to be aware of once a patient is returned to the community setting?
Yeah, that's another very important question. So, getting complete blood count and with a differential to look at what their, if they have a low neutrophil count, then if they have a low neutrophil count, you can give them, GCSF to help improve the neutrophil count. If they have, also monitoring their immunoglobulin levels, IgG levels often, and then, providing IVIG support, which can also help them prevent infections, especially viral infections. Giving prophylactic antibiotics is another, important thing. I also tell my patients that if they, get a fever or come down with an infection, to actually, reach out proactively and so that, you can intervene sooner. Even though the CAR T-cell therapy is complete, patients are still immunocompromised. And, they may not be able to mount the right amount of immune response to fight their infections off. And so that's where the supportive care is really essential at that point.
And so for my next question, I was curious if you would elaborate on what should I do if my patient is unable to tolerate the toxicities of CAR T-cell therapy? And are there other treatment options that may be available for those patients?
Yeah, so, CAR T-cell therapy, as you know, is a one-time treatment. So there is no second cycle or any maintenance, at least in follicular lymphoma that we know of. So once they've gone through the CAR T-cell therapy, if they're having a lot of toxicity, the best thing we can tell them, and it's a lot of it is on us to tell them to hang in there, to let the team really do everything possible to manage the toxicity and not give up. So, allowing the treating team to do everything in their hands to reverse the toxicity and get them back to baseline needs a certain amount of emotional, psychosocial support to get them through that. And then, of course, after that, if the patient's back to baseline and if the follicular lymphoma is in remission, then hopefully your patient is not going to need a subsequent treatment unless the disease relapses. But if it does relapse, then certainly options are available. So if they haven't seen a bispecific antibody, then I think that would be an option. There are other treatment options which are available as well, like small molecule inhibitors and things like that. So lots of treatment options available, but we got to get through the toxicity part. And good to know from the data, both real world as well as the clinical trial data, that the toxicities are mostly reversible.
Thank you. This has been a wonderful discussion today, and we've touched on a lot of different points, focusing initially on the relapsed refractory follicular lymphoma setting and looking at potential prognostic markers and how they may impact patients' outcomes. We do have now many active agents in the relapsed refractory follicular setting, including CAR T-cell therapy, bispecific antibody therapy, along with other novel agents. When we think about CAR T-cell therapy, this is often a treatment which does require time to operationalize. And so we encourage things like early referral and really being able to collaborate with the community oncologists to best manage and monitor patients that undergo this treatment. So I'd like to thank the audience for their participation and time today. And also, of course, I'd like to thank Dr. Ghosh for all of his thoughts in the treatment context of relapsed refractory follicular lymphoma.
It's been a real pleasure. Thank you so much. It has been a great discussion. I also want to thank the audience for excellent questions and in a very relevant topic. So thank you again.